NCS Part 7 Focal Nerve Lesions. Focal nerve lesions we will be discussing in order of peripheral nerve structure, types of nerve injury, demyelinating lesions, axonal lesions, conduction block, Wallerian degeneration, preganglionic versus postganglionic lesions. Structure of peripheral nerve. The peripheral nerve consists of myelinated axons, unmyelinated axons, Schwann cells, supporting connective tissue. The supporting layers are endoneurium, perineurium, and epineurium. The functions of these layers are protection, elastic support, prevent damage from pressure and stretch. Myelinated versus unmyelinated fibers. Unmyelinated fibers cover only by Schwann cells. They are slower in conduction. Myelinated fibers have multiple layers of myelin. They have faster conduction. Saltatory conduction occurs in myelinated fibers only. Nodes of Ranvier. These are the gaps between myelin segments which are rich in sodium channels. The action potential jumps from one node to the another. Causes of peripheral nerve injury. Common mechanisms are compression, ischemia, traction, laceration. Example, carpal tunnel syndrome, compression, trauma, laceration, dislocation, traction, vascular compromise, ischemia. Classification of nerve injury based on the damage to myelin, axon, or connective tissue layer, classified as neuropraxia, axonotmesis, neurotmesis. Neuropraxia, it is mildest form of nerve injury. The pathology is focal myelin damage. Axon remains intact, no Wallerian degeneration. The mechanism is segmental conduction block near the node of Ranvier. The causes are mild compression or ischemia. Recovery is usually rapid and complete. Electrodiagnostic findings of neuropraxia. Nerve conduction study findings are distal stimulation will show normal CMAP, whereas proximal stimulation will show reduced or absent CMAP. The impulse cannot cross the demyelinating segment. The key point here noted is the presence of a conduction block. Axonotmesis definition. Here, axon is damaged but supporting structure remains intact. Features are Wallerian degeneration, possibility of regeneration, but recovery is slower than the neuropraxia. Usual causes are crush injuries and severe compression. Neurotmesis, it is most severe form of nerve injury. It is characterized by features like complete disruption of nerve, connective tissue damage, and there is poor spontaneous recovery. It often requires surgical repair. Electrodiagnostic study cannot accurately separate all the three degrees of nerve injury. The third one, neurotmesis, has been classified as third degree, fourth degree, and fifth degree. Third degree, endoneurium is disrupted. Fourth degree, perineurium is disrupted. Fifth degree, complete nerve is transected. Demyelinating mononeuropathy. What happens in demyelinating mononeuropathy? The focal myelin injury will lead to conduction slowing and conduction block. Electrophysiological hallmark is conduction block. Conduction block is the failure of action potential transmission across the lesion. The NCS pattern here is distal stimulation producing normal CMAP, whereas proximal stimulation producing reduced or absent CMAP. It is classified as partial conduction block and complete conduction block. Localizing the lesion. The technique is to stimulate distal to the lesion and then proximal to the lesion. Interpretation: normal distal response with abnormal proximal response indicates lesion between the two stimulation sites. Limitation 1. Phase cancellation. The problem is temporal dispersion may falsely reduce the CMAP amplitude. This occurs because different nerve fibers conduct at different speeds. Important criteria for true conduction block are reduced CMAP amplitude, reduced CMAP area, and no major prolongation of CMAP duration. To say there is a conduction block, there should be 50% drop in amplitude and area with no major prolongation of CMAP duration.
Limitation 2. Distal demyelinating lesion. The problem is both distal and proximal CMAPs become low. It mimics axonal degeneration. The clue to demyelination is rapid improvement within weeks due to remyelination.
Limitation 3. Axonal loss conduction block. Early axonal injury can mimic the conduction block. Initially, distal axon is still excitable, so distal CMAP is preserved. But later, Valenian degeneration develops and distal CMAP falls. So, repeat NCS is very important. Limitation 4. SNAP limitation. SNAP normally show the temporal dispersion. Therefore, sensory potentials are unreliable when diagnosing conduction block. Focal slowing of conduction. This is caused by paranodal demyelination. It can occur as synchronized slowing conduction or desynchronized conduction slowing. Synchronized slowing. Here all fibers are equally affected, so distal latency is prolonged, conduction velocity is reduced. CMAP amplitude is normal, duration is normal, and no temporal dispersion is seen. Desynchronized slowing. Here, different fibers are slowed unevenly. CMAP becomes dispersed, duration becomes prolonged. Important point here is conduction velocity may still remain normal because fastest fibers are spared here. Axonal loss mononeuropathy. Acute axonal injury will cause Valerian degeneration. So there is low CMAP amplitude and absent CMAP in severe lesions. CMAP and axonal loss. CMAP amplitude reflects number of surviving motor axons. But in chronic phase, we have a problem, that is collateral sprouting may falsely increase CMAP amplitude in a chronic lesion. Conduction velocity in axonal loss. Usually, conduction velocity remains normal or slows mildly. It slows because of selective loss of fast conducting fibers. Early axonal injury. In the first 48 hours, distal axon is still excitable. So, NCS will show distal stimulation, normal CMAP, proximal stimulation, reduced CMAP. This is called axon discontinuity conduction block. Valerian degeneration timeline. The CMAP changes begins falling by 1 to 2 days. They reach the nadir by 6 days. SNAP changes occur much later and they reach the nadir by 10 to 11 days. Repeat NCS study after 10 to 11 days to differentiate demyelination versus axonal loss. In demyelination, distal CMAP is preserved, whereas in axonal loss, distal CMAP is reduced. Importance of early localization. Before Valerian degeneration, conduction blocks helps to localize the lesion. After degeneration, CMAP becomes diffusely low. It results in localization becoming more difficult. Needle EMG. The role here is to detect the denervation and identifying axonal loss. The limitation is localization is less accurate than conduction block studies. Preganglionic lesion, example, radiculopathy, root avulsion. The lesion location, it is proximal to the dorsal root ganglion. Why snaps remain normal is dorsal root ganglia remains intact here. Therefore, peripheral sensory axon survives, resulting in snap being remaining normal. Findings in preganglionic lesion, snap remains normal, needle EMG is abnormal, CMAP may be reduced if severe motor axonal loss is present. Postganglionic lesions, example plexopathy, peripheral neuropathy. Lesion location, distal to the dorsal root ganglion. Findings, SNAP is abnormal, CMAP may also be abnormal. Demyelination versus axonal loss. Demyelination, main pathology is myelin damage, conduction velocity is slower, conduction block is common, CMAP amplitude is preserved, recovery is faster. Axonal loss, main pathology is axonal damage, conduction velocity is mildly slowed, conduction block is early only, CMAP amplitude is reduced, recovery is slower. Conduction block versus temporal dispersion. Conduction block happens because of failure of fibers to conduct. Temporal dispersion happens because fibers conduct at different speeds. Both may reduce the proximal CMAP amplitude, but temporal dispersion primarily causes waveform broadening. Progressive proximal stimulation. This figure demonstrates the effect of progressively proximal stimulation of the median nerve on both the CMAP and SNAP. The median nerve is stimulated at four different sites: palm, wrist, elbow, and axilla. In the upper panel, CMAP are recorded from the thenar muscle, while in the lower panel, SNAP are recorded from the index finger. As stimulation is moved proximally from palm towards the axilla, the CMAP waveforms remain relatively preserved in amplitude and in morphology, despite a slight increase in temporal dispersion. This occurs because motor fibers have comparatively less variation in the conduction velocity, and the muscle's response itself acts as a physiological integrator that minimizes the effect of desynchronization among individual motor axons. Although there is some spreading out of the waveform from proximal stimulation due to different arrival times of fast and slow motor fibers, the individual motor unit potentials still overlap sufficiently to maintain the overall CMAP amplitude and the area. Therefore, a normal motor nerve conduction study, proximal stimulation usually causes only minimal reduction in CMAP size. In contrast, the SNAP in the lower panel shows a marked reduction in amplitude and area with progressively proximal stimulation. Sensory nerve action potentials are much more sensitive to temporal dispersion because they represent the direct summation of numerous individual sensory fiber action potentials without the buffering effect seen in muscle recordings. As the conduction distance increases, small difference in the conduction velocity among sensory fiber become exaggerated, causing the individual sensory potential to arrive increasingly out of phase with one another. This results in significant phase cancellation, where positive and negative waveform component overlap and partially cancel each other, leading to smaller recorded snap amplitude. Thus, even in normal nerves, proximal sensory stimulation produces greater waveform dispersion and amplitude loss than motor stimulation. This physiological phenomenon becomes even more pronounced in demyelinating neuropathies, where conduction slowing is uneven among the fibers. Understanding this difference between CMAP and SNAP behavior is essential in nerve conduction study because it helps explain why sensory responses are often more affected by temporal dispersion and why interpretation of proximal sensory recordings requires caution. Compound muscle action potential. This figure explains the relationship between fast conducting and slow conducting motor fibers in generation of CMAP and demonstrates how temporal dispersion and phase cancellation affect the motor conduction studies. In the upper panel, representing the distal stimulation, the conduction distance is short, so action potential traveling the fast and slow motor fibers arrive at the muscle nearly simultaneously. The individual motor unit responses therefore remain synchronized and summate efficiently, producing a larger CMAP amplitude. Even though there are slight difference in the conduction velocity between fibers, the duration of motor unit potential is relatively long, allowing substantial overlap between the responses. Because the waveform remain largely in phase, there is minimal phase cancellation and summed CMAP retains its size and morphology. This illustrates the normal physiological condition in which motor fibers conduct in a coordinated manner, generating a stable muscle response. In the lower panel of the image, representing proximal stimulation, the conduction distance is longer, so the latency difference between fast and slow motor fibers become much more pronounced. The slow fiber response arrives later, producing temporal dispersion between individual motor unit potentials. However, unlike sensory potentials, motor unit potentials are broader and longer in duration, so the response still overlaps considerably despite the delay. Therefore, the amount of phase cancellation remains relatively small and the CMAP amplitude decreases only minimally during normal conduction. In demyelinating neuropathies, however, conduction slowing becomes markedly uneven, greatly increasing the latency differences among the fibers. Thus, figure highlights the important electrophysiological principle, that is, motor responses are relatively resistant to physiological temporal dispersion, but pathological demyelination can significantly distort CMAP morphology and complicate interpretation during neuroconduction study. In this figure, we can see illustration of the mechanism of phase cancellation in SNAP caused by difference in conduction velocities among fast and slow conducting sensory fibers. In the upper panel, representing the distal stimulation, the conduction distance is short, so the action potential generated by fast and slow sensory fibers reach the recording electrode almost simultaneously. Because the waveforms are nearly synchronized, their negative peak align in phase and summate effectively, producing a larger snap amplitude in the summed response. The individual responses reinforce one another rather than interfere, resulting in a sharp and high amplitude sensory potential. This demonstrates how, under normal conditions with minimal temporal dispersion, sensory nerve fibers conduct in a coordinated fashion and generate an optimal summed electrical response. In the lower panel, representing the proximal stimulation, the conduction distance is longer. The difference in conduction velocities between fast and slow fiber become more apparent. The slower fiber response arrives later than the fast fiber response, producing temporal dispersion between two waveforms. Because sensory potentials are short duration, biphasic waveform, this delay causes the negative phase of the fast fiber to overlap with the positive phase of slow fiber. The opposing phases partially cancel each other, a phenomenon known as phase cancellation. As a result, the summed snap amplitude becomes substantially smaller despite the fact that all fibers are still conducting normally. The figure demonstrates approximately 50% reduction in amplitude purely due to desynchronization, not due to axonal loss or conduction block. This explains why sensory nerve action potentials decrease significantly with proximal stimulation even in healthy, and also why sensory responses are particularly sensitive to demyelination, where unequal slowing exaggerates the temporal dispersion and phase cancellation further. This figure summarizes several important abnormalities seen in nerve conduction study, using the ulnar nerve as an example, and demonstrates how different pathological processes alter the CMAP. The recording electrode R records the muscle responses after stimulation S at different sites along the nerve. In partial conduction block, in panel A, the figure illustrates demyelinating conduction block. Under normal conduction conditions, proximal and distal stimulation produces CMAP of similar morphology and amplitude because impulses conduct normally across the nerve segment. In partial conduction block, however, some nerve fibers fail to conduct across the demyelinating segment, causing a significant reduction in proximal CMAP amplitude, while the distal response remains preserved. In complete conduction block, no impulse traverses the lesion, resulting in absence of proximal CMAP despite the preservation of distal response. This pattern is characteristic of focal demyelination and is commonly seen in acquired demyelinating neuropathies. Panel B demonstrates the focal synchronized slowing. In example A, the distal latency is prolonged, while conduction velocity remains relatively preserved, indicating a focal distal demyelination. In example B, conduction velocity across a nerve segment is markedly slowed, indicating segmental demyelination within that segment. These abnormalities occur because myelin damage slows saltatory conduction without necessarily causing the axonal loss. Panel C demonstrates focal desynchronized slowing, also known as temporal dispersion. In this condition, different nerve fibers conduct at markedly different velocities because of uneven demyelination. As a result, the proximal CMAP becomes broadened and dispersed, with loss of waveform synchrony and reduction in amplitude due to phase cancellation. Unlike conduction block, impulses are still transmitted through the lesion, but they arrive at different times, distorting the waveform morphology. Panel D illustrates the electrophysiological evolution of axonal injury after the nerve trauma. During the first 3 days after axonal discontinuity, distal nerve segments remain electrically excitable because Wallerian degeneration has not yet occurred, so distal stimulation still produces CMAP. However, by approximately day 7, Wallerian degeneration progressed distally, resulting in conduction failure and disappearance or marked reduction in distal response. This distinction is clinically important because early nerve conduction studies after trauma may appear deceptively preserved despite severe axonal injury. Overall, this figure highlights how NCS can differentiate demyelination, conduction block, temporal dispersion, and axonal degeneration based on the changes in CMAP amplitude, latency, conduction velocity, waveform morphology, and making it an essential tool for lesion localization and pathophysiological diagnosis in peripheral nerve disorders. High-yield summary, the key points are: conduction block suggests demyelination. CMAP amplitude reflects axonal integrity. Valerian degeneration affects CMAP earlier than SNAP. Repeat NCS is important. Normal SNAP with radiculopathy suggests you have preganglionic lesion. Focal nerve lesions are classified by degree of myelin injury, axonal damage, connective tissue involvement. Electrodiagnostic study helps in localizing lesion, differentiating demyelinating from axonal loss, assessing severity and prognosis.